It's a big pleasure and honor to be here today and to have this talk. And I would like to thank especially also Professor Masatoshi Murase, who invited me for this symposium and giving me the chance to have this talk, and especially also to have this very intense exchange during this month of being a visiting professor. So many thanks. Today I would like to talk about suffering from an evolutionary perspective, which includes the application of the self-nonself circulation model of Masatoshi Murase for medicine. I was very impressed yesterday and also today about brilliant researchers talking about topics of nature. I consider myself to be a medical doctor, a clinician, and most what I have learned about the topic I talk today about suffering is as a clinician. I worked for many years in the University Hospital of Zurich, where I treated physical illnesses as a psychiatrist, and I learned a lot of patients suffering from cancer. I saw parents losing their child, suffering them as a couple. And so the topic I talk is mainly an experience topic. In this time, I had also the chance to develop a tool which helped me to understand very fast the suffering state, and it helped me a lot as a clinician. What I want, this instrument I would like to present today to you. Actually, for the last 10 years, I have now been working as the medical director of this clinic close to Zurich, where we tried for our 70 patients to implement the knowledge, understanding of suffering in clinical practice. So that's my background. Today, I would like to introduce you our model of suffering and also this visual tool called PRISM. Also all the time in a perspective of a clinician. Then I would like to introduce the self-nonself model and try to have a bridge to the thinking of suffering. And I would like to have then at the end some conclusionary thoughts. Suffering is a paramount phenomenon, and if you see at arts here, you see the famous picture of Munch, the Scream of 1893. Also in literature, in films, suffering is paramount. Also, religions have dealt a lot about this topic, and I think one of the most deepest understanding of suffering is surely presented by Buddha, and he developed with his Four Noble Truths a way of understanding suffering and of treating suffering. So just by stating that life has to be considered as suffering, and that the suffering has as a cause is due to attachment or craving or desire, and he claimed that this attachment or craving can be eliminated, and that there would be a methodological way to do such elimination. Also, in my belief system, in Christian belief system, there is a very large literature and thinking about suffering, and the idea of the crucifixion of Jesus seems to be that as he is seen as the Son of God, knows suffering, there is for all human sufferers a form of understanding by God. So this means you are not alone, somebody understands your suffering. As I said, I'm working in the field of medicine, and it was astonishingly fact that when I started to think about suffering, I perceived that there's a huge lack of a theory of suffering, and there were also no keywords in our database, Medline. It's hardly not found in any book of medicine or health psychology. And although it's very often used, it's hardly ever defined explicitly. And often you find just an equation of suffering is illness or suffering is pain, but surely that's not true. So in the field of medicine, there is a lack of theory of suffering, although the main goal of medicine is to relieve suffering. So that's quite astonishing. I would like now to present you this visual tool we developed just about 20 years ago. We, this means Professor Tomsensky from Imperial College of London and me, and it's a very simple tool that somehow gave us a lot of insight into the understanding of suffering. This tool, I would like to show you the real instrument. Looks like this. And it's shown to patients and introduced as if this would be your life, and this would be you in your life, and the problem or illness is then presented as a red disc, and it's just a question, where would you see the place of illness actually at your life? That the patients start to think about the situation, grasping this disc, putting it on this table, and giving us some information. This first information, which is used mainly in research, is just the distance between the two points, between this self and illness point, and it was astonishing that this distance correlated highly with important other information. So we found that the closer the distance, the smaller the distance, the higher the level of symptoms of depression, anxiety. There was also a time information. The closer, the more people were thinking about the problem, and the more they felt that they lost control, the personal control over the situation. More fascinating to us were when we listened to patients, when we asked them, what does this mean? What does this mean to you? And we analyzed a lot of data of these talks, and we perceived that patients would give us enormously personal, important information in a very short time, when they were explaining the meaning of this distance. And when we analyzed all this data, we recognized that there is something new, because when we started, we were interested in a measure for coping. We wanted to understand how patients would deal with chronic illness, but then when we somehow had a look at the data, the qualitative and the quantitative, we were recognizing it's something new. So we started to describe it's something like a burden of suffering, in German Leidensdruck, and now, with years going on doing research, we believe that PRISM is a generic measure of suffering, and that important aspects of this suffering have to do with illness intrusiveness, controllability, but also loss of roles. That's also a very important aspect of suffering. We did a lot of work in a validated tool, and we found that we could somehow do this validation concerning face validity, convergent, divergent. It's also astonishingly sensitive to change. So if you treat a chronic illness and there's a decrease in symptoms, you have a very sensitive change to the measure of PRISM. As there was no criterion validity, so there was no gold standard, what actually suffering meant, we couldn't do this validation. Now, concerning research, we have now studied more than 10,000 patients in different fields of medicine, and it's finally, in 6 years ago, it's accepted as the best generic measure for suffering. It's also used broad in all over the world, on all continents, in the field of medicine, in psychiatry, palliative care, rehabilitation, nursing, physiotherapy, occupational therapy, and in the last 10 years also in other fields like coaching, marketing, human resources management, teaching. But here it's more understood as a metaphor of a relevant subject-object relation, and I come back to this a bit later. How could we define suffering? I think the best definition in medicine is presented by Cassell in the New England Journal of Medicine more than 30 years ago, and he said, suffering is a specific state of distress associated with events that threaten the intactness or integrity of the person. What is a person? I think that's very difficult. We would see it phenomenologically, that a person has many facets, many aspects, like personality, past, life experiences, family, background, roles, also relationship with himself, activities, regular behaviors, secret life. Also perceived future is important, and the transcendent dimension, spirituality. All these facets can be the origin of suffering. So suffering is also perceived as loneliness and isolation. So there's all time, we did also a lot of research, studied literature. Suffering is all the time associated with a perceived isolation and loneliness, and with a certain experience of pain, but it's not the pain that is just perceived by bodies, it's the suffering of a person. I will come back to this. So I think we can consider suffering also as a comprehensive pain pattern. Pain, if you have some background, neurophysiologic background, is seen as a complex interaction which is structured in a so-called pain matrix. We have areas that are mainly perceiving sensoric information. You have a strong effect of affective, emotional neurons, and there is also this cognitive motivational aspect of pain. And these three aspects shape a behavior, a pain behavior, which is very important. Just about 10 years ago, a new research started about the topic of so-called social pain. This work done by Eisenberger et al. Was coming from an evolutionary idea of pain. The idea was that the threat to the intactness of person is somehow monitored by a pain system. We normally think when pain is perceived to the danger of physical damage, but as a mammal and human beings need being integrated in a group, she had the idea that being outside of a group is also a high risk for survival. So that if you're isolated from a group, there could be also a form of pain, she called it social pain, which should be perceived. And to me, this links closely to the idea of suffering. The studies are quite complex. How can you study this social pain? Her studies are done in computer gaming. You have a group of playing a game, and then you exclude suddenly somebody without any explanation, and you have a look at his reaction, about his perception, and about also his brain activity. And you find that there are that there's this perception of feeling bad, of sort of pain, and that also pain areas are activated. She did also studies with subjects. They had a disturbance in pain perception, so problems with morphine receptors, and she found that the social pain is correlated to the physical pain. So if you have a problem in perceiving physical pain, you have also less social pain. So I think that's an interesting concept of the social pain, which leads me to a classification of chronic pain. A bio-psychosocial understanding of pain, and I would like to give you a first group of pain. Is just body damage, so it's nociceptive or is a damage in the nerves. You see here you have it's strongly biological, and it's a bit all the time. It's aversive. It's psychological, but there is not a big reaction concerning social interaction. If you have a next group, if there is if you develop a sort of psychiatric comorbidity, and typically it's first anxiety and then depression, you have a stronger effect on the psychological, but it's also a change in social interaction. And as a third group, it could be that these patients suffering from fibromyalgia, that's a strong pain disorder without any physical reason, could be that it's mainly a social isolation state, which has no effects on biological reasons, physical, but it's very strongly also psychological. So that it would be a form of classification of pain in this view, and I think chronic suffering could be also a form of a strong social isolation, which is all the time present. So let me now go in the next step. So how can we understand suffering? I would like to lead you to through this diagram. We start here with the threat to self, which is all the time the cause, the starting point of this perceived suffering. We see that suffering all the time somehow induces questions about your definition of a self. I will show you data on this later on. I would like to focus first on this very important aspect of that suffering induces a process of finding personal meaning, which somehow is also linked to the societal meanings of suffering. So if you live in a group of people believing in certain in the meaning of suffering, that has a big effect on individuals to find personal meaning, but it's also linked to individuals' capacity to find meaning. So we find huge differences in adaptation to this state of loss or damage. Let me now try to explain a bit this finding personal meaning. We can see in clinical trials that there are two aspects of finding suffering, meaning in suffering, and we have a first reaction that's a question of making sense. So why me? In different groups of people, like parents having lost a child, being diagnosed with cancer, with a chronic illness, you see about 85% of all human beings have this reaction. Why me? It's automatic process. It can be very strong. So as psychiatrists we say it's ruminating, and we see that the quantity of this why me question strongly correlates with psychiatric symptoms like anxiety and depression. So if you have a very strong why me reaction after 1 year, you're getting coming close to psychiatric disorder. After 3 to 9 months after the loss or trauma, then a new process starts, which is not backwards, but it's in the future. It's the question of finding benefits. So what might be the sense of what's happening? And it's a novel construction of self and the world, and we call this, and I will come back to this, the information that people give us about what they found to the meaning of them for the future. This construct is post-traumatic growth, and I will talk afterwards about this. So if you have a loss, there's first a causal going back, and then it's after 3 to 9 months a starting of a final perspective. So why for? That's these are two processes which we can see. This why for information, so if you ask patients what, if you think back, was there anything positive about this experience, they give you a lot of information, and then it was classified, and we found this information. So people think that due to suffering, to this loss, they perceive changed quality of relationships. So it's a more intense quality, but they lose quantity. So they thought about having many friends. At the end, there were few, but it's more intimate. It's more intense. They say we appreciate life different. So it's you lose something, but what you have is experienced more deep. It's also that people say, I survived this, so I feel a new personal strength. And a fourth point is, many people say this, and it's quite interesting. If you talk to Swiss people, just openly, were there any positive aspects? And we did this with 50 couples who had lost their baby, a prenatal baby. We hardly find spiritual religious beliefs to be mentioned. In the States, it's very dominant that the people would say, yes, it has had a big effect on my understanding of God and my belief. And the fifth aspect of post-traumatic growth is it's setting new priorities in life. So it's a different view on what's important. So we can say that this post-traumatic growth includes a higher intensive subject-object relation, and the second would be it's an adaptation of core concepts, which somehow happens in those who who tell us about positive effects. You have experienced possibly yourself suffering, you have seen around you suffering, and you see these reactions are really very, very different. And to me, as a clinician, it's just fascinating that everybody reacts so different to similar situations. As a clinician, it was one of my biggest searches to understand how can I understand these different reactions. In this trial to understand suffering, I think I would like to, one idea which to me seems to be very central, suffering is a relation between the subject and the problem. So I'm very interested about stress resilience or resistance of people dealing with the problem, and so we were looking for concepts which could explain resilience and also measure resilience. And I would like to present you, to me, a really fascinating concept which is called Salutogenesis. I don't know who knows Salutogenesis. Okay. I think it's a fascinating concept because it, you normally in medicine, you're focused on the sick parts of the body and you try to understand sick illness. Here, so normally in medicine, we are concerned about illness, look for reasons for this illness and for the weaknesses. If we would like to understand reactions, like suffering reactions, we should also think about the very interesting questions: why other people who were also somehow in contact with this virus or with the bacteria are not sick. So we should think about what keeps, somehow regulates health and what helps persons to be protected in all this struggle for life. So what somehow is the structure, the process of keeping healthy. Ideas of salutogenesis led to this is a concept developed by this Israeli sociologist Aaron Antonovsky, and his knowledge was developed in a group of women. He was doing research in the 70s in Israel, where he was looking about menopausal reactions, and he found that about 1/3 of the women were in the Holocaust, in the concentration camps, and he found, that's a pathogenetic idea, they stay much worse than those who haven't been in the concentration camp. It's ordinary thinking, interesting, but he was astonished that about 1 out of 4 of these women were quite healthy. And he started to have a look at them, to understand them, and he analyzed the interviews, and he found at the end 3 factors which somehow have this resilience factor called sense of coherence would compromise. And he found that those who were resilient would see themselves as persons able to understand internal and external stimuli. That is the first aspect, comprehensibility. Second is, they had the idea that they would have an effect on internal and external stimuli. And the third is that called meaningfulness, that this all what happens, all this struggle in life somehow have a basic meaning. It's an emotional concept. It makes sense somehow. I would like now to go to our study where we tried to understand different patterns of suffering within a group of patients suffering from an autoimmune disease called systemic lupus erythematosus, SLE. This disease is an illness that affects mainly young women at the age of about 18 to 13 is the beginning, and it's a chronic disease. It's inflammation of arteries in all your body, which creates symptoms of fatigue, pain, renal failure, and has also sometimes effect on the brain function. We did a comprehensive assessment of these patients. There were just 12. The core information was a long-standing 90-minute interview with these women. We did also assess psychological variables. We assessed suffering with PRISM. We assessed with 13 questions this sense of coherence, resilience, and we assessed the post-traumatic growth, also with a questionnaire. Also, the physical state was thoroughly assessed. When we analyzed the data, we found in these 12 women 3 really different patterns, which I would like to present. A first pattern was shown in persons that felt destroyed by the illness, and they had a high long-term suffering. There were also women that were hardly not affected as a person, and they showed a low long-term suffering. And there was also one pattern that to us was the most fascinating. It was a comprehensive change of the person, but a medium suffering. And I would like to give you now 3 stories, narratives of patients showing the meaning of this pattern. The first pattern is shown by a 42-year-old lady. She is working in visual graphics, and we asked her, who have you been before this illness started? And she said, I've been a very active person. I did sports, I loved traveling, I had many friends. To me, to be independent was very important, and she loved to be outside in nature. When we talked about the actual situation, she became very sad and said, you know, my life, this disease was developed about 15 years ago. I'm destroyed. So it's just everything, lupus, and I cannot do any sports. I have problems to meet friends. I feel totally dependent on this state of my illness, and there remains just one aspect, nature. She's going biking sometimes, but she would have a high suffering and a huge negative perceived change of her situation. Second pattern was shown in a very impressive 63-year-old lady. She was a scientist. And when you asked her, who have you been before this illness developed, she told us, you know, to me, knowledge, my job as a scientist was very important, and my family, that's my life. And when you asked her, who are you now, she said, you know, it's about the same. I still work in the lab, I have a good family, and I have lupus, but it wouldn't affect me so much. I'm just sometimes tired, but I'm about the same person. Pattern 3, to me, the most fascinating pattern was shown in a 37-year lady who developed lupus at the age of 18. We asked her, who have you been before lupus? And she said, you know, I just love to go to parties. And how come? She said, I'm the only girl in our family. I had to look after my mother, suffering from multiple sclerosis. So I needed to go out, and because I had to do so much for my mother. She had friends. She was a very good student at high school. after, when she was diagnosed, she had a breakdown, as the doctor would tell her, you know, you have a very severe form of lupus, and you should not have a family, because when you are pregnant, this will affect the illness very much, so that's very bad. And she and her boyfriend decided, forget it. We want to not listen to this, we just start a family. And she said, you know, I have now 3 kids. I'm very happy with my family. I still have my mother I'm looking after. I have not so much time, but I have many friends. I still need to go out, not to be close to my family sometimes. And the only really negative aspect of her life was that she, due to the fact that she would have a family quite early, she couldn't study, and she would work as a clerk and was not very happy with her job. When we asked her, where do you perceive your illness, she said, lupus is present. Sometimes when it's active, it takes a lot of energy, but I can live with it. And at the end, she said, if I would like to give you one further information, I became a devout Christian. I am now in a church, and this gives a lot of meaning to me. So I have changed a lot, but to me, it's positive overall. This change was a big positive change. So if we have the 3 patterns and we assessed this resilience, we assessed the suffering and the growth, you see in the first patient there was a low resilience, a high suffering, and hardly any growth. In the second patient we had high resilience. This was this lady with being a scientist. She had a low suffering, hardly any suffering, and she would have some positive effects of illness growth, but not so much. The last patient, she had a medium resilience, she had medium suffering, but she had described a big personal growth. So I think that's amazing to see how different people react depending on their resilience and the relationship of the problem in contrast to her personal resilience. What are we doing as clinicians with this information? I would like to give you just an idea as a clinician what I perceive as the goal of therapy. We try to help patients from a state of decompensation to a state of integration after the loss or the chronic illness, and that's a very difficult endeavor. Because you have to deal as a human being with something you don't want to have. You want to push it outside of your life. You don't want to get in touch. The most important step in therapy is that people understand somehow I have to accept it. It will be part of my life, and it doesn't mean that I just will have a resignation, so just to be a victim, but we call this acceptance active resignation. So it means, yes, I don't want to have it, it will be part of my life, but I take responsibility in dealing with the problem. So that's a big step, and it's one of the most difficult that people, our patients, understand. Reasons to come to a psychiatric clinic will not be taken away by therapy. We want to help them to regulate the problem, and this is the most important inside step, acceptance. I come now to my idea of integration of this self-nonself circulation model for suffering. we have the expert here, but nevertheless I try to summarize what I understood of your theory. I see you talk about this self-nonself circulation, so that in all evolution you have this relation of a self to a non-self, and this interaction constitutes complex processes. It's a simple situation, but a very complex solution. And this is somehow the basic structure of development of life. So you have this structure easily seen here in this cell, where you have outside information of a vesicle coming inside the cell and putting outside information by exocytosis. So that's the basic structure. So it's a self, non-self circulation. And from an evolutionary perspective, it's a process that starts very simple and creates a lot of new interactions with this simple self-non-self interaction, and it has the effect of this wonderful nature we talked about yesterday and today. So this creativity, everything is starting in this interaction and being in a evolution in time. So how should we apply this idea to the understanding of suffering? One is, it's very evident that we can see PRISM as a very simple visualization of this self or subject to non-self relation in a certain context. So that's evident that it's very similar to this idea of this creation of life. When we discussed these processes of suffering, we thought it's a learning process which can be seen in suffering, and integrating the theory of Piaget, who describes two forms of learning. One is the assimilation, that you have new information which can be integrated in old structures, and you have a second, which is accommodation. This means you have to change basic structures to include the new information. We thought that surely suffering is a learning process which has to do with accommodation. So let me first give you an example of assimilation. This is a learning process shown by a young boy with studying a newspaper, seeing information about watches, then seeing that her teacher, his teacher has also a watch, listening to the watch, and then thinking, I want to listen to this. That's a learning process which I would call assimilation. But suffering is now something much more difficult and much more comprehensive, because it's linked to self-concepts and values. So the loss of an important aspect of a person jeopardizes the self-evaluation, changes the meaning of some aspect of individual self-concept, and has two different accommodation processes. One is the reconceptualization of the self. I showed you in these three patterns that persons change the idea about themselves. And very important, it's a review of values, which I have shown you in Posttraumatic Growth. So if you include all this, we would define suffering from an evolutionary perspective as a painful learning process to adjust core concepts about oneself and the functioning of life. So it's an integrative view on suffering. To us, it seems to be novel to integrate this idea into suffering. I'm coming to the conclusion. I hope that you think like that the application of this self-nonself model to suffering is novel, and I would like to show you it has clinical effects. Suffering is discomfort and deprivation, but it's not sufficient to cause suffering, because this experience of suffering depends on an experienced loss of meaning and purpose. So suffering ceases to be suffering when it takes on meaning, and the attitude to this suffering is paramount. This is a citation of Viktor Frankl of his logotherapy, so meaning is paramount. I think that including this self-nonself concept, this idea, it could create some form of meaning to the individual. And I think we could also think about societal meaning of suffering that it has an impact or when we somehow think about the evolutionary process of accommodation. I think that we need a paradigm shift in medicine. As I have shown you, there is hardly any discussion about suffering, and how come? I think it's deep-rooted that we had a time, a medieval time, where there was a holistic perspective, one universe, and medicine was included in disciplines of philosophy and theology. And since the Enlightenment, we have a different attitude. It's just a body functioning, it's a machine. And I think we have to develop this model to include important information for understanding. So I think we should think about thinking about this self-nonself circulation model to be a new framework, I would say, for medicine. And I think it's a really comprehensive model that includes science and humanities. It's evolution-based and not human-centered. I think that's very important. And I think also this future orientation is and goal orientation makes it as a real an idea of having it as the future framework for medicine. So thank you very much for your attention.